Hi there, good afternoon. Welcome, everyone. We'll wait a few minutes as people join the webinar and then we'll get started. Thank you all so much for joining us today. Alrighty, good afternoon and thank you all for joining us for ITEP's Policy Forum, Changes and Opportunities, calaim for California's older adults and dual eligibles. My name is Emily Castillo and I am the Director of Programs for Insure the Uninsured Project, or as we commonly refer to ourselves, ITEP. Before we get to the main agenda today, I have some important housekeeping notes for you. This webinar is being recorded and will be available on the ITEP website. I've asked my colleague Shirley to pop that link in the chat below for you. Attendees can listen to this webinar through their computers or by dialing in using the number and passcode provided by the Zoom software. We also welcome you to utilize the closed captioning function. Just click on the CC button at the bottom of your screen to enable the live transcription feature. Today's webinar will run approximately 2 hours and have 3 main panels, each followed by a question and answer session. If you have questions during the webinar, we encourage you to submit your questions using the question and answer panel, which you can also find at the bottom of your screen. When submitting a question, please indicate if it's directed at a specific speaker. We will answer as many questions as we can throughout today's webinar. Also located at the bottom of your screen is the chat panel. Please feel free to use this function to say hello or chat with other attendees. We will also be posting relevant information and links throughout the webinar here. So without further ado, it is my pleasure to actually get us started on the agenda for the day. Again, my name is Emily Castillo and I represent ITEP. For those of you who are not familiar with us, we are a 26-year-old health policy nonprofit and convener with 3 key focus areas: coverage and access, in keeping with our original goal of ensuring the uninsured, delivery system transformation, and the future of health and the health system. Our mission is to promote innovative and workable policy solutions that expand healthcare access and improve the health of all Californians. ITEP implements its mission through policy-focused research and broad-based stakeholder engagement. We are thrilled to be hosting this webinar today with the generous support from the SCAN Foundation. This webinar is the result of a collaborative partnership between ITEP, the SCAN Foundation, and the California Collaborative for Long-Term Services and Supports, both of whom you will hear from shortly. When ITEP first began this work, it was clear to us and our partners in the aging advocacy and policy space that, despite our shared goal to achieve an equitable health system for all Californians, there was still a broad disconnect between our 2 communities. But where we identified a divide, we also identified opportunities, ways in which our unique communities and networks could partner, collaborate, and work together to bridge that divide, to leverage the intersection between systems of healthcare delivery and aging. To that end, we've invited you, our attendees, representatives from both sides of the bridge, to engage with state, health plan, community leaders, and each other to find even more opportunities for partnership, engagement around our shared interests. So I would now like to invite my colleagues from the SCAN Foundation and the California Collaborative for Long-Term Services and Supports to say a few words. With us today is Narda Ipakchi, the Vice President of Policy for the SCAN Foundation. She's an experienced health and aging policy professional with deep expertise in policies and programs that support older adults, including Medicare, Medicaid integrated programs, and long-term services and supports. Also with us today is Maria Kalina, Executive Director of the California Collaborative for Long-Term Services and Supports, who, while relatively new to this capacity at the organization, has played an active role in managing administrative functions, supporting strategic development efforts, and leading advocacy and policy activities since its inception in 2011. Thank you both so much for being with me today. I'd like to first start with Narda and then go to Maria. Narda?
Thank you so much, Emily. I'm so glad to be here with you all today. As Emily mentioned, my name is Narda Ipakchi. I'm the new Vice President of Policy for the SCAN Foundation. Joined just about almost 2 months now. And I'm currently based in Washington, D.C. and have spent most of my career working in federal policy. But as we all know, federal policy and state policy very much inform each other. Most recently, I was the Medicare Medicaid Director at the United States Senate Special Committee on Aging, working under the leadership of Senator Bob Casey of Pennsylvania. And in that role, I had the opportunity of working on policy at the national level but my work was very much informed by what was happening in the chairman's home state of Pennsylvania. And again, making sure that federal policy and state policy were informing one another. I'm really excited now to be able to be working on California policy, a state that is so on the cutting edge in terms of advancing care and well-being for older adults, and really prioritizing the aging population. I'm also really excited to be able to ensure that the work that's going on in California can help inform the national dialogue, and that when this conversation is happening at the national level, we can ensure that California is a part of that discussion, and the resources, the regulatory environment, the legislation that's being developed at the national level will help to benefit California. At the SCAN Foundation, we want all older adults to have the services and care that they need in their preferred setting, which we know is home and in community. So today's discussion reflects the foundation's commitment to advancing that goal through stakeholders and advocates like you all that also work to improve care for older adults. As Emily noted in her introduction, it's incredibly exciting that today we're bringing together the Insure the Uninsured Project's broader healthcare network with the California Collaborative's Long-Term Services and Supports Network. We know that people with complex health needs, those with multiple chronic conditions, serious illness, social needs, today they have to navigate multiple complex systems of healthcare and community supports. And we know that better coordination among these various systems and services would help aging Californians and people dually eligible for Medicare and Medi-Cal be able to better achieve their goals for health and well-being. Almost 2/3 of California's dual eligible population are people of color. So not only is it a healthcare issue, but it's also an equity issue. And as many older adults from diverse backgrounds experience higher rates of illness and death, frequently accompanied by health, social, and economic disparities, which have to be addressed at the same time that we're talking about healthcare needs. Today, we have the pleasure of hearing from several experts about how California's Master Plan for Aging really provides a roadmap for system-wide change grounded in equity, and how the Department of Healthcare Services calaim initiative will bring together healthcare and LTSS to elevate the needs of aging Californians and those with complex needs. I just want to again recognize the Insure the Uninsured Project and the California Collaborative just for their tremendous work today and for organizing today's program. And I, of course, also want to thank our audience for their participation and continued interest and dedication to this population and to these important topics. Thanks, Emily. I'll turn it back to you.
Thank you, Narda. Maria?
Thank you, Emily, and thank you so much for both of your very thoughtful comments. Hi, everybody. My name is Maria Kalina, and I'm the Executive Director of the California Collaborative for Long-Term Services and Supports. For those who may be unfamiliar, the Collaborative is a cohort of roughly 60 state-level and regional member organizations that advocate for the dignity, health, and independence of California's older and disabled adults. Our membership reflects a broad cross-sector of aging and disability providers, advocates, health plans, and labor. And together we work to advance a sustainable, high quality, and cost-effective system of care that strengthens the individual, circles of support, and the community at large. Coordinated, integrated, and comprehensive care is absolutely a core principle in that vision, but we can't build this system of care in silos. To better serve this population, we have to recognize and embrace intersectionality. We have to strengthen equity. We have to learn about each other and from each other and work in tandem to identify shared values and innovate policy solutions and then bring those to life. And so it's extremely exciting to be here in partnership with ITEP and the SCAN Foundation for this conversation, which is not only a learning opportunity, but also an opportunity to foster new connections that can lead to new solutions and strategies that better address the needs of this growing population. So with that, I'd like to thank all of you for joining us today and pass it back to Emily, and I'll see you later in the program for our final conversation with community stakeholders.
Thank you so much, Maria. That's so well said. And thank you as well to Narda. For the first panel, ITEP is grateful to have our state partners who are leading this work join us today. To get us started, it's my pleasure to introduce our first moderator, Megan Burke, who serves as the Program Officer of Policy and Advocacy for the SCAN Foundation. In this role, she executes the Foundation's public policy strategies and grant making to advance state and federal solutions that improve the lives of older adults, people with complex care needs, and the family caregivers. Megan, the floor is yours.
Thank you, Emily, and good afternoon, everybody. As my colleague Narda had mentioned in her introduction, people with complex healthcare needs have a complicated network of healthcare and community supports to navigate in an effort to meet their needs, preferences, and goals. And over the years, California has made strides to better integrate and coordinate these services. California's Master Plan for Aging provides a blueprint for reimagining healthcare for all Californians as we age, and this includes calaim as a core component. So it's my pleasure today to be here with Sarah Steenhausen, the Deputy Director, Division of Aging and Policy, Research and Equity at the California Department of Aging, and Anastasia Dodson, Deputy Director of the Office of Medicare Innovation and Integration at the Department of Healthcare Services, really to discuss this policy landscape for California's older adult population. So first we'll hear from Sarah, who will provide an overview of California's Master Plan for Aging, specifically how implementation of calaim advances the goals and initiatives of the master plan. Sarah?
Thank you so much, Megan. It's wonderful to be here and wonderful to see all of you. And thank you to the Collaborative and the SCAN Foundation for supporting ITEP in this convening. So what I'm going to do is start with kind of a broader context, as was discussed, about how we think of our system change efforts, such as calaim, in light of the Master Plan for Aging. So hopefully everybody can see my slides right now. So I wanted to start, let's see here. It's not advancing. There we go. As context, I don't think anybody here is surprised by the Master Plan for Aging. I think everybody here has probably seen this slide several times. But what we really wanted to emphasize is that, as you know, the Master Plan for Aging really touches on 5 bold goal areas having to do with housing for all stages and ages, reimagining our healthcare delivery system, focusing on inclusion and equity, and addressing our caregiving workforce challenges and needs, and 5, focusing on affording aging. So all of these together really help us plan comprehensively for the needs of our aging population. But specifically today, when we talk about calaim and the related system change efforts, we really need to think about Goal 2, which is focused on reimagining our healthcare system so that it's really responsive to a whole person care model of system of care. So right now I'm going to talk a bit about calaim and Medicare and HCBS innovation and advancing the MPA goals. So here you can see that in Goal 1 of the MPA, it focuses on Strategy A of bridging healthcare with home. So really looking at innovative partnerships with the federal government, health plans, health systems, and community-based organizations, having California scale and test new models of healthcare delivery that maximize access to services and avoid unnecessary institutionalization. Second, we want to talk a bit about some of the real significant progress that's been made in this space. Most notably, the master plan called for the establishment of the Office of Medicare Innovation and Integration, really to provide leadership in this space. A lot of what Narda was speaking to points to the importance of better aligning both federal and state policy in the Medicaid and Medicare arena so that people can have access to services that are much more streamlined and reflective of their range of needs. So with Anastasia Dodson taking the leadership position in this office, it's a really, really significant step forward. And I think we'll be able to hear from her as to how systems change is really being considered in this new Office of Medicare Innovation and Integration. Second is we have some significant opportunities that I know you also all have been monitoring and discussing in your work with the California Collaborative. And again, Anastasia will provide more information on this, but moving forward with the California Coordinated Care Initiative and thinking about what we need to do to expand access to more integrated systems of care, such as those that are provided in the current Cal MediConnect plans, which will soon be transitioning to a new DSNP aligned model. Really, all of this is so critical to achieving this goal of better aligning and coordinating our healthcare delivery system. I also thought it's really important to note that with CalAIM's focus on enhanced care management and community supports, this is something specifically called out in the Master Plan Initiative 36 by expanding access to home and community-based services for people receiving Medi-Cal. Recognizing that, how people receive healthcare is just one part of the picture, but we need to ensure that people have access to a whole range of services and supports that meet their needs in the home and the community and help them remain in the setting of their choice as they choose when they age. So we're really excited about the opportunities provided by this transition to this model in CalAIM, where we have access to enhanced care management and community supports, and a lot of opportunity for this home and community-based provider network to participate in as partners in rolling it out. Next, this kind of gets along this line of, in order to realize the vision of enhanced care management and community supports, and again, Anastasia will talk more in detail about its alignment with this community and the older adults and people with disabilities. But we really need to think about leveraging our partnerships across the aging and disability network, partnering with health plans, and taking advantage of some of these tremendous opportunities to build infrastructure and ensure that the services that you all provide that are in line with enhanced care management and community supports can be part of the service delivery system. So how do we build capacity and identifying the best practices, not reinventing the wheel, but harnessing opportunities for streamlining CBO engagement with health plans. So these are really some critical opportunities for everybody at this moment so that we can achieve this vision of expanding a more affordable, accessible, integrated service delivery for all older adults and people with disabilities who are dual eligible and eligible for Medi-Cal only. So in addition to these significant system change efforts related to CalAIM, I think it's also really important to point out that even if we have a very integrated, coordinated service delivery system, that delivery system won't mean a lot if we don't have the services and supports in place across the state. So central to this effort of building a more integrated service delivery system, the master plan calls out in Initiative 40 to apply for federal funding to assess and plan for home and community-based services in all counties. And this is something that the LTSS subcommittee in developing the master plan for aging really prioritized, which was essentially a home and community-based services gap analysis and roadmap, so that we can understand where the gaps in the system are, and most importantly, build out a plan for filling those gaps and meeting the needs across the counties with a core set of services that are available to everybody as they age. So right now, we're really excited. The Department of Aging is working with the Department of Healthcare Services. They're launching a gap analysis that we are partnering with them on, and it's going to look not only at the range of home and community-based services in the Medi-Cal program, but also those home and community-based services that operate outside of the Medi-Cal program. And we really want to get a good picture of where the needs and gaps in services are so that we can build out a service delivery system that is reflected of where the population is and addresses what they need for a truly integrated service delivery system. Also critical to this is looking at data. And if you're talking about building out access to our home and community-based service delivery system, we need to understand the programs and the services and how consumers access services across the system. So the Department of Healthcare Services is undertaking a really important effort through the LTSS Data Transparency Initiative to identify data relative to the Medi-Cal LTSS programs, service utilization, and other elements, which I think will be very informative as we move forward with the HCBS gap analysis and consider our planning efforts moving forward. What's also important is that California is on the cutting edge of looking at the needs of and assessing for the services for people who have Alzheimer's. So as we know, this is a growing component of our older adult population. And what's really exciting is that there was resources included in the budget last year to launch a Cal Dementia Aware program. And this was also called out in the Master Plan for Aging. And the Department of Healthcare Services has already developed the tool for California Dementia Aware. And it's basically establishing a statewide standard for dementia screening through an equity-focused, culturally competent provider training. And what's super exciting about this is that this can be leveraged not only by our Medi-Cal managed care plans, but also by the broader service delivery system. So I know that the state has been doing a lot of work to launch this effort, but it really is critical when we think about planning for the needs of this population and advancing the Master Plan for Aging. So finally, I've touched on a number of elements of the MPA and their alignment with calaim, but it's certainly not exhaustive of everything across the 5 bold goals and all of the different initiatives. We were really appreciative of the time that everybody took to attend the September 20th Day of Action. And we have taken all of the recommendations that the stakeholder committees brought forward. And we are at this point are working through the development of the next iteration of the plan, which will include an update to all of the initiatives. So that plan will be released in later January, as well as a annual report reflecting on the progress from the last year of advancements in the Master Plan for Aging. So I hope that that provided you with a good context for the discussion. And now I'm happy to turn it over to Megan.
Thank you, Sarah, for that great overview of some key initiatives that are being worked on in the state as part of the Master Plan for Aging. Now we'll turn to Anastasia Dodson, who will provide overview of some key components of calaim that impact older adults and people with disabilities, including individuals who are duly eligible for Medicare and Medi-Cal. So thank you, Anastasia. Hand it over to you.
Thanks so much, Megan. And let me share my slides. I'll share my screen and then go to presentation mode. Let's see, I'm having a little trouble getting to that top part where it says presentation mode. Sorry, everybody. I'll just start speaking and hopefully that screen thing along the top will disappear.
Anastasia, if you want to click on the slideshow in the top right in the middle.
Yeah, I can't see it because of the sharing screen thing on Zoom. I don't know why that sometimes gets in the way there. Anyway, so we'll just go ahead and get started. I'm sure it'll disappear on my screen in just a sec. So just to say that, not to repeat too much of what people have already talked about, but of course, older adults in California is a very fast growing group. By 2030, we expect 10.8 million Californians will be an older adult, making up 1/4 of the population. We want to note that Californians on average have one of the highest life expectancy rates in the US, which is a good thing, of course, but that also means that as we build out these systems and consider improvements, it is a growing and growing population. And so we need to think about how to scale these things up. We also have a healthier population on average compared to other states, but also significant disparities. And back to the comment about equity, that is something that's always on our mind here at DHCS. And thinking about the language differences, geographic differences, racial and ethnic differences here in California, and how do we try to optimize our programs to fit a variety of populations and communicate about all of the different benefits to all of those populations. Yeah, and again, I apologize. The the thing at the top is not disappearing. So I'll just keep going in this format. Hopefully everybody can see what they need to see. So just briefly reminding everyone, Medicare and Medi-Cal are separate programs. Some people have both Medicare and Medi-Cal, and Medicare covers doctor visits, hospital stays, et cetera. And then Medi-Cal covers the Part B premiums, and then long-term services and supports, such as adult day health care, skilled nursing facility care, in-home supportive services, and then dental and specialty mental health. And most people who have Medi-Cal in California are enrolled in a Medi-Cal managed care plan. Just some context here. But then when we look at people who are dually eligible for Medicare and Medi-Cal, sometimes known as Medi-Medi beneficiaries, they are more likely than people with Medicare only to report being in poor health. For example, hypertension rate was much higher for dual eligible beneficiaries, heart failure, depression diagnoses, Alzheimer's disease and related dementias. So just thinking about what that means for delivery system changes, enrollment and eligibility changes, and then goals overall of what do we want a healthcare system to look like for people who are dually eligible. All of this information about this higher frequency and multiple chronic conditions needs to inform our thinking and implementation. The last bullet I want to flag here is that just as far as the overall proportion of Medicare beneficiaries, about 1/4 of Medicare beneficiaries also have Medi-Cal. And then just for context, about 43% of dual eligibles were enrolled in a Medicare Advantage plan. And then over half are still in original fee-for-service Medicare. And as we think about the context for the improvements and delivery system changes that we're making in California for dual eligible beneficiaries, we really do need to have that in mind about what delivery systems are they in for Medicare, and not just the Medi-Cal side, because Medicare is the primary way that people dually eligible access healthcare services is through Medicare. So keeping in mind that dynamic around Medicare Advantage plans, and that Medicare Advantage plans have multiple lines of business. Some plans have offerings specifically for dual eligibles as in D-SNPs, et cetera, but that their clients and Medicare providers, patients include both dually eligible and Medicare only folks. So all of that you all know, I'm sure, very well, but we want to keep ourselves grounded in that as we think about delivery system changes. One last piece of table setting is that the rates of eligibility for Medi-Cal among Medicare beneficiaries vary widely across counties. So when we look at, for example, Imperial County versus Marin County, 44% of Medicare beneficiaries in Imperial had Medi-Cal eligibility, and in Marin it was just 8.5%. That's not surprising when you think about sort of income levels and income distributions across counties in California, but again, it's not uniform. And so as we think about interventions and delivery systems, we do need to consider what things look like. It's different in different counties. Same with Medicare Advantage enrollment rates. We talked about the statewide 43%, that was in 2021, it's higher now, but that varies quite a bit across counties. And even within this, like Alameda County is an interesting example. Over half of people who are Medicare only are in an MA plan, a Medicare Advantage plan, but among dual eligibles, only 28.5%. And this was, again, as of 2021. Los Angeles County, it's more even. Close to half of duals and over half of non-duals are in an MA plan. In Butte County, it's much lower, but it's still more consistent. Most people on Medicare are not in a Medicare Advantage plan. So all of that is just to say, when we think about these policy designs and levers, we need to think about what's happening on the Medicare side, Medicare Advantage side, and it's not uniform. And just to flag PACE, and there's also SCAN, FIDE-SNP, those are also growing in enrollment, and different delivery system approach there, but integrated care, which of course is something the department supports. So when we look at Medicare, Medi-Cal, the need for coordinated care, Medicare and Medi-Cal, they do operate separately in many ways with different funding streams, which can be confusing and very hard to navigate for beneficiaries, and oftentimes doesn't provide person-centered services. And for people who have multiple chronic conditions and functional impairments, like dual eligibles, that's very challenging. And since they use long-term services and supports at a relatively high rate compared to other Medi-Cal beneficiaries, all the more important that we try to get coordinated and streamlined care across those two funding programs. So the first part on the calaim piece I'm going to cover, and I do have I'm going to go through all these slides quickly because, you know, they're just doing high level. CalMedi Connect is currently a demonstration in 7 counties to combine Medicare and Medi-Cal into one health plan. The 7 counties are listed there. On January 1st, CalMedi Connect members will automatically transition to Medicare Medi-Cal plans, MMPs or Medi-Medi plans, and they're operated by the same company as the CalMedi Connect plan. And members can choose otherwise. It's Medicare open enrollment time right now, so dual eligible and all Medicare beneficiaries can choose to enroll in a Medicare plan, and there are many choices for dual eligible beneficiaries around Medicare plans in most areas. In some parts of the state, we talked about Butte County as an example, there are fewer Medicare plan options. And finally, so these new Medi-Medi plans, they are open for new enrollment in 2023, not just the existing CalMedi Connect enrollment. So new enrollment in those 7 counties is available through the Medi-Medi plans for 2023. And what are the opportunities and benefits of these Medi-Medi plans? Similar to the CalMedi Connect approach, it's not something brand new. We've just, you know, been creating this year, but has a tried and true approach already implemented through CalMedi Connect. There are simplified care coordination efforts, care coordinators and models that the plans must adhere to help members access services across both sets of benefits. There are integrated member materials, supplemental benefits, of course, community supports and enhanced care management, as we're going to talk about, are available through the Medi-Medi plans. And there's benefit coordination, a unified plan benefit package, integrated beneficiary communications. And just also want to flag that although in 2023 we have these plans enrolling members in 7 counties, there will be additional counties that will be offering these Medi-Medi plans in future years. I also want to flag that we have what's called a state Medicaid agency contract, which is our vehicle for holding Medi-Medi plans and all other DSNPs accountable for the care coordination requirements that we have. And we are already looking ahead to 2024 and what those SMAC requirements will be to continue improving care coordination. Just a quick reminder, probably already know this, beneficiary enrollment in any Medicare Advantage plan, including a DSNP, is voluntary. People can remain in Medicare fee-for-service and don't need to take any action to remain in Medicare fee-for-service. And CalMedi Connect members are automatically enrolled in a Medi-Medi plan affiliated with their current plan, and no action is needed by the beneficiary. One other quick note, I just want to flag, this comes up this question comes up a lot, balance billing for dual eligible beneficiaries. They should never receive a bill for their Medicare Part A or Part B services, you know, for the vast majority of situations. And one way to avoid that balance billing, of course, is being in a Medicare Advantage plan where it's clear that all the providers are in that plan and would be, you know, seeing that beneficiary without any confusion or concern about the secondary payment. I'm shifting gears to another calaim initiative. This is to enroll Medi-Cal beneficiaries that are not already in a Medi-Cal plan into a Medi-Cal plan. And you can see on the map the kind of the purple in the Northern California and coastal counties. Those are counties where skilled nursing facility services and dual eligibles are already enrolled in Medi-Cal managed care. And again, I'm shifting gears. We were talking about Medicare for those previous slides. Now I'm talking about Medi-Cal. And you can see in those purple counties, dual eligible beneficiaries and long-term care services are already part of Medi-Cal managed care. The kind of pink counties, those large counties in Southern California, plus Santa Clara and San Mateo, in those counties, most dual eligible beneficiaries are already enrolled in a Medi-Cal plan, and skilled nursing facility care is part of Medi-Cal managed care. In the blue, and those are the counties I want to talk about just another minute or so, those counties, people who are dually eligible for Medicare and Medi-Cal are not already enrolled in Medi-Cal managed care. Some of them may be voluntarily enrolled into a Medi-Cal plan, but starting in January of 2023, essentially all dual eligible beneficiaries, especially in those dark blue counties, will be required to enroll in a Medi-Cal managed care plan. And we'll talk in just a sec about why that is, what are the policy goals there, but just try to remember that map as we go through the next few slides of where this transition among these 31 counties in that blue color will be happening in the next few weeks. So right now, again, statewide, over 1 million dual eligible beneficiaries are already enrolled in a Medi-Cal plan. But then again, in those 31 counties, there'll be about 325,000 dual eligible beneficiaries newly enrolled in a Medi-Cal managed care plan. The list of counties is there. And I want to go to some key reminders about this transition. Being enrolled in a Medi-Cal managed care plan does not change someone's Medicare provider access. It also does not change their choice of original Medicare or Medicare Advantage. Medicare providers do not need to be enrolled in Medi-Cal plans to continue serving their patients who are dually eligible. So if you are someone that has Medicare and Medi-Cal and you're not currently enrolled in a Medi-Cal managed care plan, you will probably be getting a notice in the next week or so about needing to enroll in a Medi-Cal managed care plan. Please do not worry that that will have any change or impact on your Medicare coverage or your Medicare providers. You can keep seeing your same Medicare providers, even if those Medicare providers are not affiliated with your Medi-Cal plan. And for those of you who serve dual eligible beneficiaries, community groups, et cetera, we have fact sheets and the notices on a DHCS webpage around this effort, and we encourage you to reassure the people that you see that this Medi-Cal managed care change will not in any way impact their Medicare access. Why are we doing this? We have additional responsibilities now for Medi-Cal plans to coordinate long-term services and supports. Medi-Cal managed care plan benefits that are helpful for dual eligible beneficiaries include CBAS, transportation and medical appointments, calaim community supports, which we're going to talk about more today, as well as calaim enhanced care management. Those benefits are available through Medi-Cal plans, as well as long-term care. So having a Medi-Cal plan to coordinate all of these long-term services and supports can greatly improve the way that people are able to navigate across these services. One other piece, we call it a carve-in, but basically having skilled nursing facility care as part of Medi-Cal managed care. This is a transition, again, in those blue counties, those 31 counties, that provides kind of a more standardized approach for skilled nursing facility services and a more integrated system of Medi-Cal managed care. That means that Medi-Cal plans, they have a greater incentive to look for strategies to keep people at home or in the community rather than going to a skilled nursing facility, because they are essentially, they are needing to pay for skilled nursing facility care. So they have now a much greater incentive to look for other alternatives, home and community-based alternatives, to avoid skilled nursing facility stays. Speaking of which, I quickly go to another aspect of calaim, enhanced care management, which is building partnerships between Medi-Cal plans and community-based organizations on certain populations of focus. Many of you are familiar with enhanced care management, and I want to just emphasize that dual eligible beneficiaries are eligible for enhanced care management. And in fact, in 2023, those two additional populations of focus that are in bold at the bottom will be coming online for Medi-Cal plans. Those are members eligible for long-term care and at risk of institutionalization, and nursing home residents transitioning to the community. These two populations of focus very much involve a vast majority of those populations of focus are people who are dually eligible for Medicare and Medi-Cal. So with this focus on these ECM populations of focus, as well as the enrollment of dual eligibles into Medi-Cal managed care and the carve-in of skilled nursing facility care into Medi-Cal plans, that creates a much more comprehensive, integrated approach to reducing people's rates of institution and then being able to get out of an institution if that's what they want and back in the community. Just a couple more pieces here. calaim community supports, which are already online through Medi-Cal plans. These are also available to people who are dually eligible with Medicare and Medi-Cal. And again, one of the great advantages of being in a Medi-Cal plan for dual eligibles is they can access these community supports if they're being offered by their Medi-Cal plan. And again, that there's nursing facility to transition and diversion to assisted living facilities is one of the potential benefits through community supports that can help dual eligibles. Just want to briefly mention calaim population health management, which as for dual eligibles, that is going to strengthen the Medi-Cal plan requirements and information sharing between Medicare Advantage plans and Medi-Cal plans. So that, again, we don't have time to get into the details there, but population health management will impact dual eligible beneficiaries as well the population health management service. I should also mention the calaim behavioral health efforts, no wrong door and standardized screening and transition tools. Those also apply to dual eligible beneficiaries. So many pieces of calaim impact older adults. The last, just a couple reminders, we do also have our older adult expansion effective May 1st. So individuals age 50 and older, regardless of immigration status, if they meet the income limits, they can be eligible for Medi-Cal. And really important, we had a change in policy just this past summer. The Medi-Cal asset limit increased to up to $130,000 for one person. It used to be $2,000. So many more people are eligible for Medi-Cal and can apply through the county office. These last few slides are just reminders of all the work groups and webinars that we have. So with that, I'll stop sharing and hand it back to Megan.
Thank you, Anastasia. Gosh, there's just so much transition and change and great things happening. Just thank you for that really in-depth overview of calaim, the DSNP transition and everything. We just have a couple of minutes here for a little Q&A. And so if you do have questions, if you could place them in the Q&A feature on Zoom, that would be really helpful. But we do have a question, just start out probably for you, Anastasia. It's just, how will the state monitor the enhanced care management and community service use among dual eligibles and older adult Californians to ensure the services are accessible?
Good point. Good point. We are looking at the data, frankly, as we speak. There's a data lag. So, and some of, the community supports just started this year, enhanced care management just started this year, and it's been kind of phased in. So, but basically DHCS is collecting the data from the plans. We are in the process of looking at it, and then in going forward, we will be sorting out exactly what is the public reporting that we'll do and what other type of accountability. But absolutely right. We want to make sure that we've set these wheels in motion, making sure they're working properly.
That's great. So how, knowing that, you have kind of the list of the community supports that health plans will be providing, and I believe that was available online at one time, how might people, how might individuals find out a little bit more about the services that are available, especially since plans can provide different services? And how might providers or supports people who are supporting these individuals reach out on behalf of clients to kind of learn more about the calaim's services?
That's a great question. And actually, when we were talking to the independent living centers yesterday about this, they asked the same question. But for those 325,000 dual eligible beneficiaries who need to choose a Medi-Cal plan, maybe they might choose a plan based on what community supports are being offered. So we do have a chart that's on the DHCS website that lists community supports offered by each Medi-Cal plan. And we can, send that link out. But I think, certainly we would encourage the Medi-Cal plans themselves to post that information too. But for now, again, we have the chart, and then I think we can think about in the future, because people can change their Medi-Cal plans every month if they want. So we don't encourage that because of, transitions of care, et cetera. But if they find that there's a community support that another Medi-Cal plan is offering that they want, they can change to that other Medi-Cal plan.
That's great. Thank you, Anastasia. And one more question for you. And I found this one quite interesting. As one of our attendees raised that whole person care had some limitations when it came to immigration status, or limitations, I guess, at the federal. So will calaim have similar, similar limitations when it comes to immigration status?
Right, good question. So there are the Medicare rules for who is eligible for Medicare based on various immigration status, is somewhat different than Medi-Cal, but for people who are eligible for Medicare, and then also eligible for Medi-Cal, then they can choose from those Medi plans as well as many other Medicare options. For the enhanced care management and community supports, I'm not aware of any limitations there based on immigration status. Although, I'm not the expert, but I think it's all the same as my understanding. And for many of the other pieces of calaim, we don't really distinguish based on immigration status, because again, people can be eligible for full scope Medi-Cal regardless of immigration status.
Yeah, great, thank you, Anastasia. And Sarah, I'd love to turn to you with a question that one of our viewers posted. Gets to what are some of the other considerations outside of healthcare services and the services offered through ECM and community supports that are needed to promote person-centered care and provide older adults and dual eligibles that best opportunity to live independently and healthily for as long as possible? Sarah, you're muted.
Okay, thank you so much. No, I think that it's a really important consideration about how we consider what, I think it really gets to how we're trying to define the core services that are available by county, that everybody's needs are different. So while one person might need access to some sort of enhanced care management, and maybe, their caregiver needs a little bit of respite support, another person might have different needs and not need any of those services. I do think that the community supports, the 14 different community supports that are being offered by calaim are very innovative and really go a long way in meeting a range of non-medical needs that people might have. But I think it's also important to look outside of our Medi-Cal service delivery system. We have a lot of really critical programs run out of the Department of Aging, as well as the Department of Rehabilitation, Department of Public Health, that address other issues that people might have or might need. And I think we also need to consider the issue of engagement. Ensuring that older adults and people with disabilities have opportunities to engage in society, whether through employment or volunteerism, but making sure that we're really focusing on inclusion as part of our approach to aging with dignity and independence. So I think that we just need to really think comprehensively and in partnership with the local communities and people serving older adults and people with disabilities to make sure that we're getting an accurate picture of what are the range of services people need to remain at home and avoid institutionalization.
That's great. Thank you, Sarah. I want to just extend our gratitude to Anastasia and to Sarah for your time today and these great presentations, just helping us to better understand what is going on in the world for older adults, people with disabilities, and folks who are duly eligible for Medicare and Medicaid here in California. So now I'd like to turn it back over to Emily.
Thanks.
Thank you.
Thank you so much, Megan. And yes, I'll echo those sentiments to Sarah and Anastasia. Thank you for sharing your time and expertise with us today. So next up, we are so excited to have representatives from 2 Medi-Cal health plans that cover many counties across California. We know they are doing much of the work preparing for calaim initiatives that impact older adults, dual eligibles, and long-term services and supports. So with that, I'd like to introduce our second moderator, Athena Chapman. Athena is the president of Chapman Consulting, which provides strategic planning, meeting facilitation, regulatory analysis, and organizational support. Athena, take us away.
Great, thank you so much. I want to thank you, Emily, and thank the SCAM Foundation, ITEP, and the California Collaborative for Long-Term Services Supports for putting this together. And thank you also to the previous speakers for laying the groundwork and helping define many of the things that we will be talking about here today. So in this session, Medi-Cal Health Plan's perspective, serving older adults through calaim, we have the opportunity to hear from some health plan experts and learn more about how the initiatives under calaim that impact older adults and dual eligibles are being implemented through Medi-Cal managed care. We will hear from an experience and perspective of implementing new benefits such as enhanced care management and community supports, which you just learned a little bit about. And we will also hear about the work being done to prepare for some of the transitions of dual eligibles that you also heard about, moving more dual eligibles into Medi-Cal managed care, the carve-in of the long-term care benefit in certain counties where it's not already part of the managed care benefit, and the transition to the exclusively aligned enrollment dual eligible special needs plan, and lastly, moving towards a pathway to manage long-term services and supports in 2027. Our speakers today will share their experiences and lessons learned from previous pilots, such as the Coordinated Care Initiative and CalMedi Connect, which were part of the foundation for several calaim initiatives that impact older adults and those dual eligibles. About challenges and opportunities to improve care and integration for this population, as well as insights about what it takes to implement calaim under Medi-Cal managed care. It's really my pleasure to introduce our panel, and I do want to again remind you to please put your questions through the Q&A button at the bottom of your screen throughout the session, as we will have a few minutes for some moderated discussion to answer those comments and questions. So quickly, I'm going to introduce our speakers. First, we have Jessica Hampton, who is the manager of Enhanced Care Management and Community Supports at Central California Alliance for Health. She is a knowledgeable healthcare professional with a variety of experiences, including community involvement, education, project management, and leadership. She also has worked in health promotion, service quality, community engagement, strategy, and the management of complex needs. In her work at the Central California Alliance for Health, she has continued to fuel her passion for supporting strong solutions to ensure that people receive high quality care through promoting health equity and well-being, while actively assisting in making positive impacts within the healthcare community. And following Jessica, we will hear from Bo Henneman. Bo serves as the Regional Vice President of Local Engagement and Plan Performance for Anthem Blue Cross. In his role, Bo provides oversight and leadership for the quality management, marketing, and community relations and county management teams across California. In his over 6 years at Anthem, Bo has also held statewide responsibility for directing and overseeing operations, business strategy, and alignment for special programs such as long-term services and supports, health homes, whole person care, and calaim. He has over 19 years of experience in program development implementation within Medicaid-based programs in both public and private organizations. So as you can hear, we have the experts here with us today with lots of passion and expertise, and I will pass it off to Jessica to start her presentation.
Thanks, Athena. I will share my screen. Bear with me. You guys will probably see me very largely at first, and then we should be in the presentation. Happy Thursday, everybody. Thank you for joining us this afternoon. I am the Enhanced Care Management and Community Supports Manager for Central California Alliance for Health. And so Central California Alliance for Health is a managed care plan. We are a county organized health system. We serve over 350,000 members across 3 counties, Santa Cruz, Monterey, and Merced counties. In 2024, we'll be expanding to include 2 additional counties, but those are the 3 counties that we primarily serve right now. And then we do operate using the managed care model. We cover Medi-Cal, and then we also cover Alliance Care IHSS, specifically within Monterey County. So you guys have heard, and I think most people on this call are very familiar with enhanced care management and what that looks like. So when we're talking about older adults and dual eligibles, just wanting to call to attention, the populations of focus and when they're rolling out. So this year that started with individuals and families experiencing homelessness. On the managed care plan side, we've seen a significant number of homeless members receive this ECM benefit. It's probably been about 50% of our approved authorizations right now are within this homeless population, and that does include these older adults and the potentially dual eligible adults that are coming in the subsequent years. This year, we also included those individuals that are at risk for avoidable hospital or ED utilizations, and then also adults who have serious mental illness and substance use disorder conditions. As Anastasia mentioned, starting in January, we are going to be incorporating those 2 additional populations of focus, which will include those that are eligible for long-term care and at risk for institutionalization, and the nursing facility residents who want to transition back to the community. So we're really focusing on developing programs that meet that population health management need, the managed care plan need within the ECM and CS benefit, and also partnering with our care management team as well to identify these populations of focus and ensure that the members who meet this eligibility criteria are being plugged into the services that they need. I do think from our perspective and a learning perspective is that this is an optional benefit for members. So members can be eligible, but can choose not to engage with ECM. It is a participatory program. So on our end, really looking to capture individuals when they are interested and really working with our contracted providers, because the Alliance does contract this service out, and just working with our contracted providers to ensure the members are being met where they're at. It really is that high touch, face-to-face work within the community that we want to support. So having those community providers have those touch points with the members within the community and really get them engaged and involved within this benefit. And then when we're looking at our community supports, again, as was previously mentioned, managed care plans have the option. There's about 14 community supports available. The Alliance is offering 7. We will be introducing environmental accessibility and adaptations as of January 1st. And that's really to align with the populations of focus. So those individuals that are transitioning or those individuals that are at risk for institutionalization. So really trying to align our community supports with those populations of focus, and intending to roll out some additional community supports July of next year. But we currently offer the housing community supports, which should also be helpful for those that are at risk for institutionalization or interested in transitioning back into the community from an institution. And then also our medically tailored meals program, recuperative care, short-term post-hospitalization housing, and our sobering centers. And then for us on the ECM and CS side of things, because we do contract these services out, we're really looking at our role as a supportive factor. So our role in that is to ensure that the benefit is administered in compliance with DHCS requirements. So again, we're contracting out with those partners and really looking to engage the community and community organizations to really meet members where they're at. And so what that looks like on our end is really looking at data sharing, state reporting, and then reviewing those charts, those care plans, and those assessments for member outcomes and appropriate documentation. And then for ECM specifically, the expectation is for our providers to execute an individualized, person-centered approach for all the populations of focus. And so again, as we roll out these different populations of focus, just making sure that we are contracting with providers who have experience in servicing those populations of focus within the community so they can best meet those members' needs and really reach them and help to engage them and support them as they start into this new benefit. And then just really as we kind of start thinking about DSNPs, and those are the dual eligibles, and it's technically by all terms, it's exclusively aligned enrollment or EAE, the DSNP program, and that's that transition from CalMedi Connect. And so just giving a high level overview of what we're looking at in terms of DSNPs and how they're becoming effective January of 2023 and looking at implementation. So DSNPs are like Medicare Advantage plans, and they are adapted for people who meet those special needs and income qualifications. On our end, as a managed care plan, even with ECM and CS, we are required to meet that integrated DSNP care coordination requirements, and that includes having integrated member materials. So very similar to ECM, and I will cover this, that DSNPs do require that there is an individualized care plan that's developed and should identify any carved out services that the member needs, and then how that DSNP will facilitate access and document those referral processes. It also involves care management as well as coordination across both the Medicare and Medi-Cal benefits, and that is the primary function of the DSNP. And then, so again, on our perspective from the managed care plan, when we're looking at the DSNPs and ECM, and recently just implementing ECM this year, and as you all know that with the new benefit, both for ECM and CS, it just requires a high level of flexibility. There isn't a playbook, there isn't a what's been done in the past, best practice. So we're really, really learning as we go. And so as calaim continues to expand and we're looking at introducing new services and integrating some of these services, understanding what those overlaps look like and how as a managed care plan we're best addressing those and preparing to deal with those. And I do think it's going to require a high level of collaboration, which is always a good thing. But in terms of the overlap, so we have already acknowledged that there will be some members needing care management services that also meet that criteria for the ECM POPs of focus. And there is significant overlap across that DSNP model of care and then the ECM requirements, very, very similar requirements to help with just coordinating those services. And so the concern at the get is this could result in duplication and confusion for both members and just the care plan in general. So DSNPs, though, are expected to provide sufficient care management to members so that those members that would otherwise qualify for ECM, so they can meet that criteria, but they're not adversely impacted by receiving services exclusively through their DSNP. So really looking at how those DSNP plans are really in alignment with the same services that ECM is providing so that those members, again, are not getting the short end of the stick, so to speak, that they are still receiving all those high-level services. For 2023, DSNPs will provide integrative care management, and again, that's across both those Medi benefits, with the intent that the beneficiaries will receive any ECM-like services through the DSNP. So they wouldn't be receiving ECM and DSNP, it would be one or the other. And then for existing ECM members, because this also comes up, we do have some members that meet that eligibility criteria already. DSNPs will provide ongoing continuity of care with the current ECM provider. So again, that's that collaboration, that high-level partnership, and that's until the member graduates from ECM. So ECM, the overall goal, what we're looking at is really for members to become autonomous and being able to navigate their healthcare needs. And so as that ECM provider starts to support that member or that member starts to get more autonomous, they can then transition over into DSNP. How Central California Alliance works right now, we are approving our ECM authorizations for about a 6-month time frame. So we are doing it biannually. So providers would have the opportunity to either renew the ECM or evaluate with that DSNP partnership if it would be appropriate to move that member over into that DSNP model of care. And then I just pulled this actually directly from DHCS's website, just a quick screenshot just from a visual perspective on what this would look like, the timelines and the overlap for these members in DSNP versus in our managed care plan. So you can see that most dual eligible managed care plan enrollees are going to have ECM provided by or through their managed care plan. So like us, the Central California Alliance. And then the members have to meet those population of focus requirements. And then obviously, if they're not DSNP enrollees, that is going to continue on. Just calling attention to that third box on the left-hand side. So those DSNP enrollees, this year they were receiving ECM care, and that was provided through Cal MediConnect plan. And then through 2023, continuing to receive that ECM-like care management. But at 2023, that's going to be provided by those EAE DSNP programs. And so again, it's that partnership and kind of switching from that ECM over to the DSNP. And then by 2024, really looking at ECM care being provided completely through the DSNP, and then the requirements are still to be outlined in the policy guide. So again, just a quick timeline and overview of what that looks like and some of the overlap that us as care plans and other care plans are looking at and how we're implementing this. And again, really looking at navigating some of the uncertainties. There is no playbook. There is no, again, best policy. This is how we've done it in the past. And so really looking forward to seeing partnerships, collaboration, communication, and really promoting that community support, because at the end of the day, it really does take a community to help support these members and really understand what's going on. And so looking at elements like data sharing and care management platforms and closed loop referral systems, so that there's a high level of information sharing so that these members can have a robust care management plan and can begin to navigate their healthcare autonomously and just see improvements in their overall health outcomes, and really looking at focusing in on that health promotion piece. And with that, I will stop sharing my screen and I will pass it over to Bo, who will go through some additional information. So Bo, you can take it away.
All right, thank you very much. Let me share my screen. And all right, hopefully you guys can see my screen here. So I want to talk a little bit about our experience with some of these multiple programs that have led into calaim to start off with. So Anthem Blue Cross, we are a relatively large health plan in the state of California. We've been around serving the Medi-Cal population since 1994, are currently spread throughout 29 counties in the state of California, covering about 1.4 million members. And that is a footprint that will change when some of the counties go through model change and move into a COES model system in 2024. But for the next year, we're still in 29 different counties. As Athena kind of said when she was introducing me, I've been working really with a lot of the different programs that have fed into calaim for the last several years across our 29 counties, starting with long-term services and supports. Was part of CalMedi Connect and the Coordinated Care Initiative in 2 of our 29 counties. So only 2 out of 29, but those 2 were Los Angeles and Santa Clara, so they were relatively big counties, and we've been doing that since the CCI and CalMedi Connect started back in 2013. Have also implemented several other programs leading into calaim, including health homes. We were part of health homes pilots in 6 counties for the last 2.5 years. The whole person care pilots, which were driven by counties. We partnered with 10 of our counties to implement the whole person care pilots. And then I think the last thing I'll call out is this one little circle towards the bottom that says SDOH strategy. And so we've actually for the 3 or 4 years leading into calaim and community supports, had several pilots that we had run in different parts of the state, focused on housing navigation, recuperative care, medically tailored meals, different things like that. So it had built up some level of experience prior to calaim being launched and having community supports in place. So I'm not going to go into a lot of detail on what enhanced care management and community supports are, but I did want to give a little bit of an overview of how things have gone so far for Anthem across our 29 counties. And so, with enhanced care management, as of July 1st, we do have an enhanced care management benefit live in all 29 counties throughout the state. Because we were engaged in the health homes pilots and the whole person care pilots, we did have a pretty sizable population that transitioned into enhanced care management on January 1st. So about 4,500 members that moved from those programs into ECM. In addition, in total, up to this point, well, this was as of September 1st, I think, we had served 7,400 members through our enhanced care management program, and had done that through contracts with 90 different providers across the state. And those providers are, quite a bit of variety in the provider type. Most of them, I would say, are federal qualified health centers, or FQHCs. We do have contracts in place with some non-FQHC CBOs, with some counties, county public health and county behavioral health departments, and a couple of other community-based organizations spread throughout our counties. one thing that I'll say about this and our experience leading up to this is, you know, when you look at that number of serving 7,400 members across the state, you know, in the first 9 months of the program, you know, and you think about the size of our population, which is 1.4 million members. That doesn't seem like a lot of members who have been engaged in enhanced care management up to this point. But I'll tell you, it's actually a number that I think we really feel pretty good about. You know, the way the enhanced care management program is designed, it is only meant to serve about 1% of the Medi-Cal population. So this is a program that's really focused on members who have a high level of need, really need this high level of in-person, face-to-face, ongoing intervention of care coordination services. So definitely not a program that is designed to serve a large chunk of our members, but you know, at 7,400, we're definitely well below that 1% at this point. The reason I feel good about that though is because we have to understand that, you know, these programs are programs that are currently in development. Even though we launched on January 1st of this year, they are evolving programs in which we're growing every single month and improving upon the delivery system and getting more and more members connected to the services. And really, this is something that falls in line with experience that we had with some of the other programs that we've implemented over the last 5 years. So, you know, when I think back to our implementation efforts around the state's health homes program or some of the whole person care pilots, which both fed into this enhanced care management benefit, it really took in both cases about 2.5 years before, you know, things really got to a point where, you know, the programs were running well. We felt comfortable with the number of members that we were engaging in those programs and really starting to see some results. And so while I think we had that experience, you know, leading into enhanced care management, which helped us stand up the program and get things moving a little more quickly, it's still, you know, a new program that everybody's starting to work through. And so, you know, I am confident that within the next year, we're going to get to the point where we have the right individuals, all the right individuals identified. We have a substantial amount of our membership engaged in this program, but it is something that has to build over time. And 90 plus contracted providers across 29 counties, that sounds like a lot when you put it on the bullet in the slide, but I can tell you it's not. And you know, it is something that we're continuing to grow, to build out that provider capacity, to build out that network, especially with the additional populations of focus that will be going live next year, which includes individuals who are looking to transition out of long-term care, as well as individuals who are on the verge of being placed in long-term care, but want to remain in their communities. So looking at community supports, again, this is something that we went live with across all 29 of our counties in January. And you know, across the 29 counties, we are providing all 14 services, but I will say it looks very different from county to county. Our implementation of community supports has really been focused on what is the existing infrastructure in each one of our communities? What are the top priorities for each community? And let's figure out what do we need to stand up first with kind of this 2-year plan of working towards having all 14 services available in all 29 of our counties at some point over the course of the next 2 years. So, you know, when we started in some of our counties, we had as many as 10 or 11 of these community supports that went live on January 1st. In some of our counties, we only had 4. And again, you know, that's really dependent on what that infrastructure is, you know, and while we had whole person care and health homes in 10 of our counties across the state, there's 19 counties where we didn't have any infrastructure. Of our 29 counties, many of our counties are very rural communities and not as resource rich as a county like Los Angeles or the Bay Area. And so, you know, really working to engage at the local level, find local providers to provide some of these services is something that is been a work in progress. But I feel like we do have a good start to the program. We did have 1,400 members who were grandfathered in on January 1st and have provided up to this point 7,500 authorizations year to date. And that is, you know, well beyond the number of authorizations that we thought we were going to have for the entire first year. And again, acknowledge that that's a relatively small number given the size of our membership, but it is a number that we see growing month after month And you know, I think this program is going to have a substantial impact at some point in the near future. So the last thing I'll talk about, well, two quick things that I'll talk about. One is, you know, really looking at the aligned D-SNP model. I think Jessica gave a great overview of that. You know, I'll just add to it that, you know, we really see this as a great opportunity to better serve the older adults in our communities, the ones who are dually eligible, getting both Medicare and Medi-Cal services. We were engaged in CalMedi Connect, like I said, in 2 counties through the course of that program, but it was a limited program, and you know, something that never expanded across the state like the original plan that was in place for CalMedi Connect. And so, you know, I think this new model that we're working to under calaim will allow that intensive level of care coordination across the Medicare and Medi-Cal benefits to spread across the state, and really excited about, you know, the additional opportunities that having things like community supports and having that long-term care population carved in, and you know, really having that better opportunity to serve members through some of these programs and make sure that they're getting the care that they need and able to stay in their community. And then the last thing I'll say, I know I'm running short on time, and we'll just spend a minute on this, is, you know, along with everything that we're standing up with calaim, we have launched a calaim incentive funding and capacity building program. And this is something that, you know, the state pushed to the health plans. And so I know all health plans are doing this across the state, but this is a tremendous opportunity under calaim. Between this and PATH cited funds, which DHCS are rolling out now, it's really an opportunity for community-based organizations to receive funding to build out the local infrastructure, whether it's staffing needs, it's IT infrastructure, whatever it is, so that they're able to participate in these programs and help us serve the members that we're identifying. So it is a pretty substantial amount of change, you know, about $1.5 billion over the course of the next couple of years. And it's something that, you know, we've rolled out across our 29 counties, and over the last several months have made about, I think so far, about $10 million worth of investments in local community-based organizations to support with these types of things and get them prepared to provide these services. So I will stop there and turn it back to you, Athena.
Thanks, Bo. Thanks, Jessica. We do have a few minutes for some questions, and there's been some coming in from the chat, so I'll try and consolidate here. There were some themes. And so the first one is about how to connect folks and really educate them about these new benefits. And then maybe if they don't qualify for enhanced care management through a population of focus, you know, how do you sort of help them navigate the system and get the services that they do need? Because there's much, you know, many layers underneath those enhanced care management. So Bo, we'll start with you.
Yeah, I mean, I think in terms of just educating members and the community as a whole about these benefits is really an ongoing effort. And you know, similar to, you know, what I said about health homes and whole person care, where it took a couple of years for the programs to really solidify, this was part of it, like getting the broader provider community aware of these and making sure that they're talking to Medi-Cal beneficiaries around these services, making sure that there's plenty of member communication coming out that doesn't just come from the health plans. It takes everybody really working together to raise the knowledge of this. And so I think that's a work in progress. And we do see that we're getting more and more referrals every month. And so, you know, I'm confident that things are moving in the right direction. In terms of the second part of the question, you know, what if somebody isn't eligible for ECM? You know, Anastasia mentioned this briefly, the population health management program requirements that are starting next year as part of calaim. And really the core behind that, you know, just even not thinking about like all the data sharing and everything else, but one of the core pieces around population health management is making sure that as a health plan, we have a process to identify what our member needs are and connect them to the right level of intervention, which means that if somebody's referred to me for enhanced care management and they're not eligible, it's not just us responding back and saying, nope, sorry, you didn't meet the eligibility requirements, right? It's really looking at the other services that are available, whether it's through the health plan or through the community, and making those connections. So that member may not be eligible for enhanced care management, but maybe they benefit from some of the community supports. Maybe they could benefit from the community health worker benefit that just went live, which we haven't talked about today. Maybe they need a simpler version of case management that the health plan provides. So it's really working to push that member through that process and connecting them to the right level of care to meet their needs.
Thanks, Jessica. Do you have anything to add to that?
I was just going to say, I think each care plan does it. I think, just based on the community and the needs. And so I know on our end, our big focus in terms of reaching members is contracting with those community-based providers so that they are in the community. And like Bo mentioned, just having those conversations within the community with our community partners. We have a no wrong door approach referral system. So anybody can refer themselves, if a member can refer themselves, a family member can refer a member, a PCP can, a hospital can. So it is really that no wrong door approach. And in addition, if somebody is not eligible or doesn't meet those eligibility requirements, for us internally, what we do is we still connect them with our telephonic case management services or social work services. So that way there's not a gap, and really just trying to meet the members where they're at. And I think exactly as Bo mentioned, we're also gearing up for that population health management piece and looking at some complex case management and introducing that in addition to the DSNP program. So having a variety of avenues for some of these members who might not necessarily meet criteria, but still need that high level of support.
Yeah, thank you. Unfortunately, we have come up against time, so I'm going to skip some of the questions, but I will just note there was a series of questions about community supports, how you decide which ones to sort, which ones to offer. And I know Bo touched on that a little bit, and just sort of what data is collected and reported out. So a lot of interest in sort of seeing how is that done, what themes are coming out, which I'm sure we'll know more of in the coming months as we evaluate these programs. So thank you both so much. I'm going to go ahead and hand it back to Emily to keep us on time.
Thank you so much, Athena, and thank you to Bo and Jessica for sharing their implementation experiences. I would say I realize we are coming up at time, so if we didn't get to your question today, please feel free to share them with the ITEP team. info@itep.org is a great resource for you. We'll do our best to try and address your questions. Because I know we have a lot of content and speakers for you today, but we felt it was critical to make sure we provided a wide range of perspectives on this topic. We've heard from the state, the health plans, and now last but certainly not least, we've brought you the provider and community perspective. So with that, I'd like to welcome back Maria Kalina, who will lead our final panel today. As I mentioned at the beginning of the program, Maria is the Executive Director of the California Collaborative for Long-Term Services and Supports. Maria, thank you so much for being with me today. Go for it.
Thank you so much for the warm handoff, Emily. And thank you to all the panelists who preceded this conversation. There's really no better way to frame our closing panel. And given the time, I'd like to dig right in by having our panelists on the virtual stage. Joe Diaz has served as the California Association of Health Facilities Regional Director for the past 36 years. And prior to that, he directed the California Office of Statewide Health Planning and Development, fondly known as OSHPD. He also served as the Undersecretary of California Health and Welfare Agency. We also have Meredith Chillemi, who's the Director of Regulatory Affairs for Leading Age California, where she engages on a number of initiatives, including calaim, but also LTSS financing and the soon to be implemented Nursing Home Quality Standards Board. Prior to her role with Leading Age, Meredith served as the Director of Supportive and Health Services at Life Steps. And last but never least, we have Lydia Misalides, who's the Executive Director of the Alliance for Leadership and Education, also known as ALE. ALE is a public benefit research and best practices arm of the California Association for Adult Day Services, CADS, where Lydia served as Executive Director for 30 years prior to her full-time transition to focus on ALE. So with that, I think before we get started, I'd really just like to give our panelists an opportunity to reflect on the discussion this far. As Emily mentioned, we heard from our state partners at the Department of Healthcare Services and the Department of Aging, as well as health plan partners. Was there anything that stood out for you as an aha moment or anything that you really wanted to underscore? And Meredith, I see you smiling, so maybe we can start with you and then jump around a bit.
Absolutely. Good afternoon, everyone. And I'd like to thank ITEP, SCAN Foundation, and the Collaborative for having us all together today. It's a great discussion. One of the things that Sarah Steenhausen mentioned was the analysis of HCBS gaps. And so that made me think right off the bat as a provider representative that we have workforce challenges. And so that's also another big part of this conversation as we mobilize calaim and all the other wonderful transformations that we want to do with population health. We're going to not be able to do that unless we have the caregivers needed. So I want to flag that. Leading Age California is very pleased that we've received a grant from the state to have the Gateway Inn project to produce 2,700 home health and CNA workers, but we need to continue on that front as providers, as health plans, and as state together to build our caregiver workforce.
Great. Thank you so much, Meredith. Joe, do you want to go next?
Sure, absolutely. I echo what Meredith has said, especially on the workforce front. There was no doubt in our mind that these last 2.5 years with COVID impacting primarily home centers and other congregate settings tremendously. It had an impact not just on the residents and patients and their families, but also on staff. And we're slowly trying to rebuild the staff as we go forward, notwithstanding the fact that we actually have a high need of additional staff based on the projections that we're looking at. California, every day 1,200 Californians turn 60. And because of the fact that we just need the staff, training them and having a strong presence to backfill those that are retiring and those that unfortunately have left for a variety of reasons, makes it imperative that we focus on that aspect of the healthcare continuum.
Thank you. And Lydia, do you want to chime in as well?
Well, I'll echo on the workforce. It's affecting all of us, and I know many of you listening, you feel that deeply as well. And I think what kind of stood out for me is that we're talking about a lot of transitions. It is really complex. So I'm so glad everyone's listening to this webinar. And I saw a lot of invitations to some members of these panels to continue to educate the community. And it's going to be really important for all of us to really wrap our heads around what is happening, thinking about our own constituents, because this is, in my mind, like a care transition for an individual. And a care transition is always a moment of risk, right? We all know that. And this is a systems care transition, but it's going to affect every single person individually. And CBAS being the first managed long-term service and supports benefit to move into Medi-Cal managed care way back in 2012. Bo was around at the time. He and I worked on this together. I'm really sensitive to the need for all of us to understand what this means for our community, our constituents, and to assist them with understanding how to navigate these changes, because they will be confused. Their providers are going to be confused. We found this in the CBAS transition, and I'll talk about that a little bit later, but to me, that was a big takeaway. And I was also struck with some hope listening to Bo and Jessica talk about how they've prepared for, continue to prepare for, and that they really view this as an ongoing learning opportunity where we're all going to learn and work together. So that's the exciting part of it.
That's fantastic. Thank you all. So I think everybody on this webinar is aware that calaim is really set to roll out in phases, with that first set of initiatives having launched in January 2022. And as speakers before us have mentioned, this next phase of implementation, which is really just around the corner, will be a really significant one for older adults. There are a number of initiatives that will impact this population starting January 2023. And there's the launch of population health management. There's the expansion of enhanced care management to members who are eligible for long-term care and at risk of institutionalization, and those transitioning from nursing homes into the community. We have mandatory managed care enrollment and the phase out of the coordinated care initiative, the carve-in of long-term care. There's just so much. So I'd like to ask each of you to share, from your perspective, what are sort of the one or two big considerations that you would urge us to focus on as we move into this implementation phase? And from your perspective, what are the canaries in the coal mine, if there are any? And Joe, maybe we can start out with you this time.
Sure. Thank you very much, Marilyn. One of the things that I always remind folks is that, in California, we have nursing homes in all 58 counties. What we often overlook is the fact that You know, the nursing home of today is really not the nursing home that it was many years ago. Talk about it as a nursing home without walls. The average length of stay 10 years ago was anywhere from 5 to 15 years. Now the average length of stay is much, much shorter. Usually it's outpatient, usually it's rehab following hip surgery, etc. But the thing that always is overlooked is that generally when you have a patient or a resident in a congregate living or an assisted living or in a nursing home, there's often and frequently someone else left behind in that community. Either the primary caregiver, who may or may not be as old as the patient and may or may not need the needs or treatments that that significant other is requiring, but eventually will be part of the calaim network. And with calaim, you know, there's 14 pieces there that impact our space, so to speak. And that is, for us, we look at calaim as the opportunity to, for the first time, integrate a system that has been kind of a walking puzzle with none of the pieces put together. AB 13.3 created the Health and Human Services Data Exchange Network, which I think is the primary thing that needs to be addressed. In order for calaim to fully function, we need to know the data, where everybody is, where the needs are, where we can apply the navigators to help coordinate that care. And I think we're on the right precipice right now. This is the opportunity to get it right. So we're excited about it.
Thanks, Joe. Lydia, do you want to jump in?
Yeah, my theme for the last decade, and I'll continue to express, is communication. And it's got to happen at various levels. So we started to talk about the various transitions that you elucidated, Maria. There's a lot of them going on at the same time. So this transition phase for duals is going to be really key for those of us who, as I said earlier, are in the best position to support and communicate with the beneficiaries. It's incumbent on us to be well educated and help them navigate and know where to go for help at that individual level. We found that during the CBAS transition, we were sounding the alarm early on about the confusion happening in the community with medical providers and health systems and hospitals because of what Anastasia mentioned earlier, the crossover billing, which is a really technical thing. But people who are traditional healthcare providers, they understand it because they deal with Medicare and Medi-Cal. And to them, it was confusing. And we did need to engage with our state partners to help sort that out. So I think we should all be on the alert for those kinds of things to come up and to solve those problems. So I think that is going to be a problem that will pop up again, particularly in the rural communities where expansion is happening, where providers are very used to being independent, and there is some just built-in resistance to managed care, whatever form it takes. So I just wanted to kind of highlight that from our experience. And then for the duals who do successfully transition and they need MLTSS, again, it's the communication between the member and the plan and the provider, either to whom they're referring or from whom that person is getting services to now, has got to be in place. And I can't just stress how important that is all along the way, particularly as care plans get developed at the plan level. The health plans are reaching out more and more to their community-based partners. And some folks are new to managed care. So all of that just leads me back to communication pathways, being clear on who the people are at the health plan responsible for various pieces of this transition, who can be communicated with quickly and easily. So that means keeping like lists updated and knowing where to go for help and for information. So those are just some of the thoughts I have initially.
Thanks. Meredith?
Yes, so along the communication theme, I want to agree wholeheartedly and appreciate that everyone on this platform today is agreeing to continue communication as we build together. half of our members at Leading Age California are actually senior affordable housing providers. And so our housers are very interested in getting involved in the calaim conversation in a more formalized way. The number of low-income individuals that are living under one roof, each community all over the state, has a lot of impact. And so our housers would like to be more involved in this communication mechanism. Jessica had mentioned so rightly that older adults need to have trusted messengers in order to enroll in things like ECM and community supports, and to even hear that these things are available. And so we're eager to partner in a different way, a more formalized way with housing and healthcare.
It's fantastic. Thank you all. I think the next topic I really want to hit on is asking you all if you could share some anecdotal evidence or stories about providers who have successfully contracted to provide enhanced care management. Can you give us a sense of what their experience has been, or maybe some of the challenges they've run into? Let's see, who should I pick on? Lydia, why don't you go first this time?
Okay, I will. Yes, we have actually formed a learning community among our CBAS providers so that our early adopters, the people who decided to dip their toes into the ECM and CS waters, could share their experiences with others. And through that, we could begin to, on a peer-to-peer basis, expand the knowledge base, support one another through these applications, and just even understanding what this is all about and if it's appropriate for that particular provider. So for those of you who are thinking about it, I would encourage you to reach out to peers and learn from each other. There's just a lot to digest and a lot to understand. So that's kind of step number one. One of our early adopters, who's one of our most energetic, smartest providers down in LA, has received one ECM contract. We have others around the state who've gotten contracts already, the early adopters, but this one I thought I'd focus on as an anecdote. So she has one ECM contract, 2 pending. She has 2 community service contracts for medically tailored meals and housing transitions. She jumped and got IPP money, IPP grant money, and she has applied for some other grants called CITED or cited, and that's in the queue right now to help her gear up and be ready for really doing a great job with this. But I just have to tell you, those of you out there who are community-based organizations and don't have a big administrative staff, this is a lot of work. She was working weekends and nights just to understand and pull everything together and apply for all of these opportunities. And on the plus side, at least in LA County, the really great thing was that all the health plans got together. There was one common application. So find out how to apply, first of all. And if you're in a multi-county area, find out if that's the case. We know LA has that. However, once you do apply and people are interested, the plans are interested in contracting with you, that's where the divergence happens. And that's where things get complicated once again. So just be aware of that. And it is a barrier, I think, for CBOs because there's so much being demanded that is geared toward large organizations with a lot of resources. And that's why the grant funds are available. But still, you really have to have some grit and perseverance to really get through this. So she's now working with her plans to make changes where they need changes. You know, again, it's diverged now, so the requirements are a little bit different, reporting what the data they want, how you report it, and so on. And now the latest wrench is IT. So IT infrastructure, can she meet it? She thought she was, but now questions are coming back. Well, are you really meeting it? So these are some of the challenges to think about ahead of time, and work with your health plans as much as you can to get some consultation from them, because it's exciting. She's terribly excited about it. I think it's going to be fantastic, but it has been a process. So I guess the bottom line is, reach out to each other and let's support each other in figuring out how best to serve our beneficiaries.
Thanks, Lydia. Meredith, do you have any anecdotal evidence to share with us?
Yes, echoing a lot of what Lydia has shared, it's definitely been a growing experience for our non-medical community-based organizations. from getting an MPI number with all the right credentials to going through the credentialing process. In LA County, our members had the same experience, that the initial phase, all the plans worked together, but then credentialing plan to plan had great variety. And in fact, many of our members have had to hire consultants to help them kind of speak plan from their social based perspective. We do have members that are providing ECM. So far, about 5% of the referrals they're receiving are for older adults. So the vast majority at this time, because of the focus populations, are for people under the age of 65 for ECM. And the other thing that I think that our members are still trying to navigate is billing. Billing is different per plan, and there's some billing snafus with some of the platforms. And so our members are, some of them haven't received any money more than $100 yet from ECM, even though they've been providing service since January. And so they're still waiting for that to be resolved.
Thank you, Meredith. Joe, do you have anything you'd like to add?
Sure. Just what Lydia pointed out, the biggest risk is, you can ask, and then when you receive, you have to really dance through the hoops. What we have found in several counties, whether it's Orange County or down in San Diego, piggybacking with a well-established organization like Father Joe's Village, which has multiple levels of care, and they are able to be the sort of the quarterback on this process. They have the infrastructure, the IT, and the consultantship through the Bank of Volunteers. They have CPAs, lawyers, and it's partnering with a well-established, seasoned organization is a far better way from our point of view in working with community-based programs. So rather than reinvent the wheel, because our core mission, of course, is level of care, but at the same time, we know there's an entourage of needs that have to be backfilled either for the responsible party or when they transition to a community-based program. So we have found just partnering up with traditional organizations has made a big difference.
Thank you, Joe. Thanks for sharing that. And I think there's just one more question I want to ask all of you, which is that, calaim is a bold transition. It's a bold vision. There's a lot of details. It's complex, but is there something that excites you, or what is it? So, what are you really looking forward to as calaim rolls out? And Joe, I know that you mentioned that this is really an opportunity to, and I quote, integrate systems that have been walking puzzles, which is so true. But maybe we can start with you, Joe, if there's anything else you'd like to add in terms of what's really exciting about this.
I think the overall excitement that I feel personally, being in healthcare for almost 50 years, is the fact that we have a very vibrant, very rich state full of resources, full of ideas. We're on the cutting edge in every technology sense of the word. This is an opportunity, I think, to really reach out to the poorest of our communities who typically have been underserved for a variety of reasons. The inequities of funding, the inequities of skilled medical practitioners. And I'm talking about counties that at the same time are the source of great wealth to California, whether it's the Imperial Valley, San Joaquin, and so forth. And I believe that by being able through calaim bring equity in the area of health and support services and housing for the unhoused in the poorest of our counties, it is the right thing to do for making and continuing to make the state as exciting as it has been.
Thank you, Joe. Lydia, do you have anything to add?
I do. I echo, Joe, your comments. Serving people who have faced health inequities all their life, immigrants who have faced trauma, language barriers, cultural barriers, all that. This is an amazing opportunity if we do it right and if everybody works together. So my biggest hope, I think I would call it, and excitement is the opportunity through all of this for us to deepen these relationships with the person, really meeting them where they are, and surrounding that person with the constellation of care, all of those who touch that person and care about their health and well-being and safety. So that, I think, is the most exciting part of it, and to keep that at our core as our vision, and to not let procedures and rules, I mean, things that get in our way that cause a lot of friction and slow things down to happen for people. I hope that we can use this as a opportunity to do that, to really streamline, focus on the mission, which is serving that person and meeting them where they are to improve their health and well-being at all levels.
Meredith, do you have any closing thoughts before we turn to Q&A?
Yes, thank you. I'm really excited about what so many of us talked about today, and that is coordinated services that focus on what matters most to each older adult. And that's different for each person. So we want to meet them where they're at. And I really liked how Sarah called out a couple of times that we're looking with the master plan and calaim in and outside of the Medi-Cal program. So the Medi-Cal program is very important, but we want to braid and weave different funding sources and opportunities so that we're serving everyone, no matter what their income level is, so that they can age with independence and grace. So I think that we have a lot of work to do, but this is very exciting.
Yeah, thank you, Meredith. And I think we'll turn to Q&A. So if you've got questions, go ahead and pop them into the Q&A feature on the Zoom toolbar. I've also got the chat pulled up, so feel free, whatever is easier for you all. And I want to highlight that I think Bo and Jessica are still on the line, and we can bring them into the conversation as well if there's questions that kind of overlap between, you know, community stakeholders and health plans. So we've got one here from Shirley. With the complexity of calaim, enhanced care management, and community supports, how are the channels of communication being kept open between state policymakers, health plans, and those who are executing these changes, so community stakeholders? Any thoughts on that? Whoever wants to jump in.
Oh, I'll just jump in and say that's a critical question and comment. Some of us have been talking about ways to facilitate that communication, what we're calling sort of a rapid response or an early warning system, where as people begin to identify some barriers or maybe some system glitches that are affecting care and rapid access to people's needs, or to meet people's needs, that those can be resolved quickly. So like one quick example, Meredith, you reminded me of this. In the early days of the CBAS transition, suddenly a whole bunch of invoices were getting rejected, and we couldn't figure out why. It took a little digging, but it turns out some of the plans had retained an edit in their computer system that required Medicare to be the first biller, the first payer. So claims were being rejected. Well, of course, CBAS is not a Medicare benefit, so that edit had to be turned off because everything was getting rejected. So it's sometimes like the simplest thing like that, but it has a huge impact on community-based organizations who are already operating on a razor's edge of financial viability. So that's just one little example, and that's a really important thing we should all keep in mind, is how to facilitate communication when we do see those problems arise.
Thank you, Meredith or Joe. Do you have anything to add to that?
Well, I reflect back to what Anastasia pointed out in her slides. There are a number of work groups that have been implemented since the start of calaim and the CCI and so forth. And I would encourage, anyone who has a little bit of time to sit on, there's various differences between the work groups, whether it's billing, whether it's outreach, but all the same, everybody's working towards the same goal. And I think by being part of some of those work groups and working committees is a good way to really integrate your organization with the workings as the planning goes on. We in our organization respond to just about every all plan letter that comes out. We send recommendations. When the department has room for comment, we'll provide it from the perspective of what it will do. As Lydia pointed out, a little glitch on the program side could save a lot of headache. But by being able to be an influencer, if you will, and recommend the practical side of what potential regulation will do makes a big difference in the outcome. And so just getting involved with the various work groups makes a big deal.
Fantastic. Well, Lydia, I think you stirred something up by talking about that challenge with issues in IT. There's a question here. Well, I think it's more of a, no, it's a question. We're hearing a lot about challenges by providers to submit billings for calaim programs specific to community supports and enhanced care management. Do you know of anything that's being done to improve this process? Any insights on that from anyone?
I know that our members that work with programs that transitioned into community support, for example, in Alameda and Los Angeles counties, where the county's facilitating billing on behalf of the CBOs and working with the CBOs and the health plans, and they're having regular monthly meetings, the billing is going much more smoothly.
That's fantastic. And a comment in the chat from Carla. Lydia, thank you for the example of IT frustrations we're experiencing it within a mass organization. So kudos to those CBOs that are actively working to resolve those. A question here for Joe. Can you speak about the progress between long-term care and plans regarding the data sharing infrastructure necessary to comply with the care coordination requirements of the MMP?
Yeah, I mentioned earlier that Dr. Galley, he's the chairperson of this, but it's the Health and Human Services Data Exchange Platform. There's a requirement which was created by AB 13.3 that that data, first of all, it'll be HIPAA protected and so forth, but the whole intent of that data exchange regulation is to be able to interface with the plans, with care providers at the extreme end, whether it's the local practitioner or the plan, in terms of being able to release data so that the provider is aware of who the responsible MP is for that person. Right now, we often lose trails, if you will, in trying to, we have patients that are, for example, in Southern California that were transitioned out of Northern California counties. And it often takes 30 to 90 days to figure out who the responsible party is. So this data platform should be going live, hopefully within the next 5 months, where we've been meeting literally almost twice a week on this. We're part of it as well. There's a number of organizations that are also represented on that board. So with that, I think we're going to be able to one of the waivers we need to get, we've already applied, and that's to the federal government to give us waiver authority under the HIPAA Federal Protection Act, which is required in order to launch this officially.
Sounds great. Thank you, Joe. I just want to elevate a comment from Jessica that there's a discussion of a marketplace that will be available with contracted consultants for organizations approved for PATH funding that can help support providers both with claims and invoicing and IT infrastructure challenges, as well as other supports. And I don't know, Jessica, if you want to jump back on or elaborate on that, but you're welcome to join us here.
Yeah. So it was just actually brought to our attention recently, I believe yesterday, actually. So DHCS is really looking at through PATH funding, because I'm sure, as you are aware, there's IPP funding, which is processed through the managed care plans, and then PATH funding, which DHCS is monitoring. And so they are looking to develop a marketplace of consultants that can help address the individualized infrastructure needs for the organizations that are receiving PATH funding. So it's our understanding that there will be kind of different categories, if you will. So whether it's claims and invoicing, if you're having specific, IT care management platform challenges, and maybe it's training challenges, onboarding, that there will be consultants available that you can apply that funding to help support the infrastructure needed. And so it sounds like more information still needs to be rolled out. I can't speak to that, but I would just encourage you to be aware of that option. And I know DHCS has a page about PATH funding, and we'll be updating that regularly, but that is something that is supposed to be coming.
That's awesome news. And also, I would say that there is still opportunity to join the PATH collaboratives and apply. So I would encourage providers to do that as well for the counties where you provide services, so that you have that natural support of meeting with people on a regular basis and raising bottlenecks so that we can fix them.
Absolutely.
Right,
And I
and
think
those
the-
path, oh, sorry, Jessica, go ahead.
I was just going to say, I think the next application opens up in December. So the first round is closed and that next application is opening up in December.
That's what I was going to say. Yes. So get on the website, everyone, and take a look at that, so you can see if that is something that you want to apply for.
That's fantastic. It looks like we have one closing question here, and this is a pretty good one. So as we all talked about during the discussion, we're approaching a precipice, and it's a moment in time where we can learn from the past. So what would you all consider to be the most important next step for your organizations in regards to implementing this massive calaim initiative? Anybody want to jump in?
That's a great question. I'll jump in because I don't have a good answer. So I'll kick it off and then see if Meredith and Joe can help me out here. That is a really great question. And because the provider community is so diverse, our state is so diverse, everyone's in different places and spaces today, and even in their understanding of this. So I think, like in any change, right, there's always the early adopters and the people who are really enthusiastic and eager and will jump in with both feet. And those are the folks that I think can help the rest of us learn and learn together. So I find the best way is really this peer-to-peer. Joe mentioned the work groups. Those are important. I think that the more communities of common interest you can hook up with around calaim, the better all over. So that would be my only thought right at this moment. How about you, Meredith?
Yeah, I would say that becoming educated is really important. And for providers, that can be daunting when they're dealing with a lot of day-to-day operational issues, especially with our workforce challenges. So at Leading Edge California, we see that as our role as an association is to make information like the data exchange framework and all of these new initiatives available in an easy format, so that while people are working with older adults, we're being able to give them information in a timely way that's easy to digest.
That's fantastic. Joe, do you have any thoughts?
Yeah, we, in anticipation, not necessarily of calaim, but when the CCI rolled out, we created a program internally called Future Leaders. And these individuals are already licensed nursing home administrators, but they are proportionately are younger people. Out of college, they finished their intern and their AIT program. And the whole purpose was to create a base of knowledge that was in pace with new programs like calaim. And our other strategy is to engage actively with universities, Stanford, UCLA, San Diego State, with specific schools that deal not only in public health, but also in IT issues. And so we're actively recruiting folks that are about to graduate and bring them into within the facility environment, so they can bring a fresh pair of eyes, so to speak, because most of us have been in it and done it and been there, but we're not quick learners, unlike some of these younger folks who seem to, be able to do the right thing at the right time ahead of schedule. So that's kind of where we're moving in as an association.
That's fantastic. That's fantastic. And I know that we're getting right to time, so I just want to close this off by expressing a huge appreciation to Joe, Meredith, and Lydia for joining the discussion today and sharing their perspectives. And with that, I'd love to pass it back to Emily to formally close this out.
Thank you so much, Maria. Thank you to our engaged audience. Thank you for submitting your fabulous questions. We know this was a lot of information. We know this was a packed agenda. Big thank you to all of our incredible speakers, our fantastic moderators. We look forward to tracking how these calaim changes are implemented here at ITEP. We know there's much more of a conversation to come, and we hope you'll join us in that conversation. So with that, I will close us out. Thank you all for being here with us today. Take care. Have a great day. Have a great rest of your week.